we'll start off with Dr. Sanjay De Bakshi, who's going to give us a talk on premalignant lesions of the colon, an approach.
Ladies and gentlemen, good morning, and we welcome you to Swiss Hotel for the IASGCON 2013. My brief today is an approach to the premalignant lesions of the colon. And this is the scenario. Globally, near 800,000 new colorectal cancer cases are believed to occur every year. It accounts for approximately 10% of all incident cancers, and mortality from colorectal cancer is estimated at nearly 450,000 patients per year. This is the prevalence estimates that reveal that in the unscreened individual aged 50 years or older, there's a 0.5% to 2% chance of harboring an invasive colorectal cancer, a 1% to 1.6% chance of an in situ carcinoma, a 7 to 10% chance of a large 1 centimeter or more adenoma, and a 25 to 40% chance of an adenoma of any size. So obviously, we need to get in at this stage, not at the first stage. What is the Indian scenario? And if we will have K. Mohandas with us in the afternoon, and if you look at this present series from 1999 to 2011, you will notice that there's been a steady increase in the incidence of colorectal cancers. If you compare the colonic cancers itself, it raises from 3.7% was the estimate to 4.3%. And 0.4 to 3 to 3.4%. But if you look at different cities, you will notice there's a distinct difference. In Chennai, the incidence has gone up, whereas in Mumbai, it has decreased. So, Mumbaikas eating better, perhaps? Just a thought. This is a normal colonic cell cycle. That the normal colonic epithelium involves an exquisite migration of cells from the proliferating Krebs compartment from the stem cells to differentiated surface colonocytes. Cells are then sloughed, and the intestinal epithelium is actually renewed every 5 to 6 days. So you can well imagine that this is a high turnover state and hence prone to genetic breakages and abnormalities leading to the formation of cancers. Now, what we shall do is, of the few premalignant disease of the colon, because of paucity of time, I'm going to stick to polyps of the colon and inflammatory bowel disorders mainly. Do you have a single or discrete polyps? What is the age of your patient? In a juvenile patient, the isolated juvenile polyps are variously known as retention, inflammatory, or cystic polyps. Isolated juvenile polyps, most common polyps found in children, 80 to 90%. Approximately 40 to 60% of polyps are found in the rectosigmoid area, considered to be hematomatous, lack malignant potential, and microscopically have cystic spaces filled with mucus and that are pretty much evident on the histology side, you can see out there. And colonoscopic removal suffices for this group. But what about multiple polyposis? You have a few syndromes in the young, and you have a diffuse juvenile polyposis of infancy, with widespread polyposis of the entire GI patient, a horrible and a terrible disease because most people don't live very long. A diffuse juvenile polyposis, where multiple polyps present throughout the GI tract but concentrated on the stomach, distal colon, and rectum, usually 6 months to 5 years of age, and it's an autosomal dominant disease. You have a juvenile polyposis coli, where the multiple polyps are confined to the distal colon and rectum in patients aged 5 to 15 years, and a purely hyperplastic lymphoid polyposis syndrome, which is not a premalignant condition at all. Diffuse juvenile polyposis of infancy, this entity occurs within the first few months of life and not familial. The entire GI tract is involved. Hematomatous polyps, but there's a high risk for carcinoma, 17% at an early age. Mutation is known to occur at 2 genes. Other congenital abnormalities exist. Patients require total parenteral nutrition, bowel rest, followed by selective resection, because they have a diffuse disease, you see. With a cumulative risk of malignancy greater than 50%, no guidelines have really been established. However, some authors recommend subtotal colectomy with ileorectal anastomosis in children with anemia, hypoproteinemia, and failure to thrive. Juvenile polyposis coli, a child with at least 5 polyps or 1 polyp and a family history of juvenile polyposis, considered to have the syndrome. Most patients have 50 to 100 colorectal polyps, may also have gastric and small intestinal polyps. High risk for carcinoma in this particular subset, 17% at an early age. Mean age for diagnosis of carcinoma is 35.5 years, and the cumulative risk for cancer in patients with a juvenile polyposis syndrome is 68% by the age 60 years, and that's the St. Mark's Polyposis Registry. So what is the suggested treatment or suggested screening schedule? Regular screening with colonoscopy and subsequent colectomy if severe dysplasia and rapid polyp growth formation or bleeding occurs. And the option is, of course, a total colectomy, rectal mucosectomy with an endorectal pull-through. Remember, this is a young group that we are dealing with, and the endorectal pull-through is easier in this subset of patients. So we come to polyps in adults. Can be sporadic, where it's less than 5, no family history, multiple more than 5 with a strong family history. The commonest polyp, believe it or not, is a hypoplastic polyp, 90% of all polyps. It commonly occurs in the rectosigmoid region during adulthood, thought to be insignificant and may possess some malignant potential in the setting of a hypoplastic polyposis syndrome. Isolated polyps can be adenomatous, divided on the basis of the amount of villous tissue into tubular, less than 25% of tubular material, tubular villous 25 to 70% of villous, and villous more than 75%. In a tubular polyp, you have less than 25% of villous formation. We do have an effect of size, and the villous element increases with the size. So therefore, if you have a polyp less than 1 centimeter, 3/4 are tubular. And if the polyp is greater than 2 centimeters, 2/3 are actually villous. So that is a tubular adenoma of the colon, and you can see the tubule formation, whereas this is a tubular villous adenoma, and you can see both tubular and villous elements out there. Now, we know for fact that there is a Polyp-Cancer sequence, and that was illuminated, very eloquently described by Jass. The resected polyp must be completely examined pathologically, histologically. Adenomatous polyps can show a benign adenoma, which may be tubular, as we've described, carcinoma in situ, or invasive cancer. Colonoscopic removal is definitive treatment for benign adenomatous polyps in patients having polyps with carcinoma in situ. If pedunculated, the polyps contain invasive carcinoma, colonoscopic removal is adequate, provided there is presence of favorable prognostic factors like complete excision, no lymphovascular invasion, clear margin, and well-differentiated histology. A follow-up examination between 3 months is mandatory to confirm the presence of absence of residual or recurrent disease. Any patient with disease, and you see here a polyp which is part malignant, part villous. So, and you need additional staging procedures like a CT scanning, endoscopic ultrasound, or endoscopic MR may be helpful. And this is one of the classifications of a malignant polyp according to the level of invasion, and it's divided into 0, 1, 2, 3, and 4, as you can see. So, in summary, long stalk polyp, well or moderately differentiated cancer, short stalk polyp with cancer limited to the head, colonoscopic removal suffices. A sessile polyp with the base involved, poorly differentiated, lymphovenous invasion, you go in for a colonoscopic resection. We have plenty of polyposis syndrome, and we'll concentrate on a few. Less than 1% of all colonic cases of FAP, autosomal dominant inherited disease. More than 100 colorectal adenomas.
Sanjay, sorry to interrupt. You have 2 minutes left.
Okay. Prevalence, as you can see, 25% with FAP do not have positive family history. Extracolonic manifestations about have other lesions together with it. Surveillance. If APC germline mutation is identified in the index patient, you go in for this is a high risk condition. If mutation has been ruled out, they fall into the generic category. If the mutational status is unclear or presence of mutation has been verified, you then put them on a flexible sigmoidoscopy starting at the age of 10 to 12 years, and first degree relatives have a 50% chance of developing polyposis. Therefore, surveillance is carried out, and the timing of surgery depends on the individual course of the disease, and the procedure of choice is a proctocolectomy or a total colectomy with ileorectal anastomosis. We have a condition called Peutz-Jeghers, where you know that this was initially thought to be completely non-carcinomatous, but if you actually look at the whole scenario, you have plenty of cancers, both GI and extraintestinal, and that is the incidence. You have leading the list is breast cancer, and this is the incidence of first and second cancers. Finally, ulcerative colitis, strict in the presence of ulcerative colitis, malignant under proven of that. Three important features are most diagnostic of malignant strictures: late appearance, locational proximal to the splenic flexure, and cause of large bowel obstruction, presence of primary sclerosing cholangitis. So that is the low risk of carcinoma. And factors that they predispose to cancer is duration of the disease, age of onset, extent of involvement, and that is the incidence, 5 to 10, 0.3, more than 40 years, you have a 75%. So recommendations is this: surveillance to people with inflammatory bowel disease, more than 10 years, and you do a risk stratification. So what we'll do is, that is the recommendation. In summary, that's a recommendation that has been suggested. Average risk, that is an increased risk. This table has been very adequately demonstrated in 2012, the GI surgical annual, so you can go through that. And that is the high risk grade of patients. Thank you.